Hello. Hello. As we get people here connecting to audio, if you've been with us before, feel free to pipe in and put in the chat where you're joining us from. Would love to know where you're coming from. So feel free to put that in the chat, and we'll give people just another minute or two to get here. All right, we got some California, New Jersey, Oregon, of course, Ken, Texas, Sun City, surprise. Yeah, hot Arizona is right. We were just talking about that. It's insane. San Diego, that sounds like a better place to be right now, Lee. I will be there soon on your back porch. All right. We're gonna have people keep coming in, and I'm gonna get us started because we have a great program to talk with you guys about today and to share with you. So I'm gonna kick this off. Welcome. So glad you guys are here with us on a Friday. And I'm Sarah Jones, CEO of PMD Alliance, and I'm excited about this because I think that this is, boy, you guys are going to love to hear the kind of things that are happening at the Shirley Ryan Ability Lab and the creative ways that this team is, creating opportunities to serve people in spite of the challenges that we have with COVID. So for those of you that are new, I'm going to give you just a little quick tutorial. In your top right corner, there's a little button and it'll say speaker view or gallery view. If you hit that, you can go back and forth, and you can go between the Brady Bunch view of all of the many boxes or just the speaker view of the close-up of the person talking. And so you can do that, and you'll be able to do that even when you have, when there's slides up, so feel free to do that. In the bottom, in kind of the middle, there's a little chat button. We invite you to put your questions at any time throughout it. We'll track them and we'll make sure to ask them. But you don't have to hold on to the end if you want to put them in the chat, because I don't know about you, sometimes I forget 10 minutes later what I wanted to ask. So we're not going to make you hold on to your questions. The more the merrier. We want to hear all about the things that are on your mind. Let's see, I think those are the little pieces of updates. What I want to do is I want to tell you about the team you're going to hear from. It's just going to be fantastic for you guys to be able to hear from. I'm going to start with Dr. Goldman. Dr. Goldman, and I want to just read to you their bios. So Dr. Goldman is section chief at the Parkinson's and Movement Disorders at the Shirley Ryan Ability Lab. And she's also a professor at Northwestern University's Feinberg School of Medicine, Physical Medicine, and Rehab in Neurology in Chicago. She's a fellowship trained movement disorder neurologist with specialty in behavioral neurology and neuropsychiatry. She did graduate from Princeton and received her MD from Northwestern University and her neurology residence in the Washington University in St. Louis, followed by a movement disorder fellowship and a master's of science in clinical research at Rush. So she comes to you with a lot of experience and a lot of knowledge. Her clinical work focuses on understanding and improving treatments for cognitive and behavioral features of Parkinson's disease, Parkinsonian disorder, dementia, Lewy bodies, and other movement disorders. She's had funding from Michael J. Fox, NIH, Parkinson Foundation, and has published over 100 research articles and books and chapters on Parkinson's disease, cognition, behavior, and other movement disorders. She's passionate about a holistic, comprehensive, and interdisciplinary team. I think you will find that as she talks about how she's really working with the Shirley Ryan Ability Lab. She's a core faculty member for the Allied Team Training and PD course offered by the Parkinson Foundation. And she's the chair of the Lewy Body Dementia Association Scientific Advisory Committee, secretary-elect in the International Parkinson's Disease and Movement Disorder Society, Pan American section, and the past chair of the American Academy of Neurology Movement Disorder section. The MDS Pan, I don't know when she sleeps. If you guys are just listening to this and thinking, does she sleep? We're gonna have to ask her husband that, because I don't know how she sleeps. She also is involved with the AAM Women Leadership Committee, editorial boards of the Movement Disorder Journal, and the associate editor for Frontiers in Neuroscience Neurorehabilitation Journal. So she's busy, and you have got an expert with you today, so you can pick her brain. Dr. Santiago Toledo is with us also. He is an assistant professor of physical medicine and rehab and neurology at Northwestern Feinberg School of Medicine. And he earned his degree in the Philippines, in Manila, and completed his training in the Philippine General Hospital. His fellowship training is in geriatric medicine and gerontology, and he got that at the University of California in Los Angeles. His focus is on physical medicine and rehabilitation. So he will talk with you about what that looks like. What does a physiatrist do? And what does that impact in terms of the Shirley Ryan Ability Lab model? And he is absolutely recognized for his dedication in caring for people with disabilities, particularly people with Parkinson's and movement disorders. Susanna Miranda is with us also. You can wave, Susanna, and they'll see you. She's a nurse practitioner who joined the Shirley Ryan Ability Lab in September of last year. She began her nursing career with a specialized field of orthopedics and pain management. And in the Department of Surgery and inpatient and outpatient. She is a passionate person who got her training at Rush. She pursued advanced training at Rush in nursing practice, adult gerontology, and primary care. And she just brings that holistic piece that, frankly, I think nurse practitioners bring such a lovely component to a therapy team. I love the nursing perspective that nurse practitioners bring. And then we have Sherry Marchbanks with us too, and she has her doctorate in physical therapy. She's a board certified specialist in neurologic physical therapy, and she treats people in the outpatient program at the Shirley Ryan Ability Lab. And she completed a neurological residence at USC and Ranch Los Amigos National Rehab Center, where she furthered her education for treating people with Parkinson's. She was on faculty at USC, so we've got people that are with you today that also are from your states. So I am going to turn it over to them because they have a lot to share with you about this amazing model that they have. So Dr. Goldman, I'm going to turn it over to you.
Great, thank you so much. Let me just share my screen and we'll get going. Can you see my slides? Someone give me a thumbs up. Looks like it's in slide mode and everything. Awesome, okay. Well, we're so appreciative of being able to spend time with you all today and talk a little bit about what we do in interdisciplinary care and telehealth rehabilitation and how we've learned to adapt and change and challenge the current times. So, okay, let's see if this advances. Great. So I'll start off and then you'll hear from the other team members. I'll talk a little bit about interdisciplinary care and some innovative models for Parkinson's disease and movement disorders. So this is a little bit of our agenda today. Cover a bit of an overview. I'll talk a little bit about, as I said, interdisciplinary care and our model and changing to telehealth. You'll get to meet the team and hear from the other speakers, and we can share how to make the most of your telehealth visits, and then talk a bit about telerehab, therapy specifics, and then we'll have time for a panel at the end for questions and comments. So you've already heard a bit about us. So I'll speak, followed by Dr. Toledo and Sherry Marchbanks, and then Susanna, our nurse practitioner, will join us for the panel. And really our work also represents so many other team members who aren't on today's webinar, our other PT, occupational therapy, speech language pathologists, nurses, social work, and so many more. So we are truly grateful for their expertise and teamwork, and we get to represent what we all do at large. Okay, so I'm virtually transporting you all to Chicago. I don't know if there are any people in Chicago or Illinois in the audience, but we'll take a very short flight trip transport here. So you'll see this is where we work. This is Shirley Ryan Ability Lab, which was formerly known as the Rehabilitation Institute of Chicago, that was started many decades ago as a premier rehabilitation hospital in the United States. And we are fortunate to work in this beautiful building that's a new translational research hospital that opened in March of 2017, located directly downtown in Chicago. We are adjacent to Northwestern Medicine and Northwestern University downtown campus, and they are our academic affiliates and longstanding collaborators. So we do quite a bit with the Northwestern Medicine group. Shirley Ryan Ability Lab as a hospital is quite large, as you can see, has about 260 inpatient beds and many, many square feet of space in which clinicians and researchers work together, literally in the same space, same time, being able to deliver translational care using state-of-the-art equipment for rehabilitation. We help patients in their rehabilitation journey, including those who have medically complex needs, other disorders such as traumatic brain injury, stroke, spinal cord injury, and of course neurologic conditions such as Parkinson's disease and movement disorders. In addition to the inpatient hospital, which is pictured here in terms of what we call our inpatient floors and our ability labs, where therapy and research happen simultaneously, we have a number of outpatient clinics. We have an outpatient rehabilitation site and several throughout the Chicagoland area for PT, OT, and speech, and day rehab models, which we'll talk a little bit about, a little bit like intensive inpatient therapy, but people get to go home to their own bed at night throughout the Chicagoland area. And of course, we're very fortunate to be able to share that we have been ranked the #1 rehabilitation hospital in the country now for 30 consecutive years. So quite a privilege to be there. So here's a brief history and information about our Parkinson's and movement disorders program that was started over 10 years ago with work led by Dr. Toledo, who you'll hear about and hear him speak, and other team members. And so one of our core programs is our interdisciplinary outpatient clinic care, which we'll talk a bit about today. And this involves a new evaluation as part of our team, listed by acronym. So our physicians, our team of physiatrists, myself as a movement disorder neurologist, our advanced practice provider or nurse practitioner, nurse, physical therapy, occupational therapy, and speech language pathology. So bear with all the abbreviations, easier to put on the slides. When we meet, we have about a 2-hour evaluation, one with the physician team, and then one with PT, OT, and speech, who we refer to as our allied health therapy team. Then we meet for a discussion, and we work on proposing individual treatment plans for each patient, depending on their symptoms, practical considerations, and designing a rehabilitation therapy program. We have core outpatient rehabilitation therapies that have one-to-one sessions. So a person with Parkinson's working directly with a PT, OT, or speech language pathologist for about 45-minute sessions. And Sherry is very much involved in those as well. Day rehabilitation, which I mentioned, requires at least 2 of the 3 disciplines, such as physical therapy and occupational therapy, or physical therapy and speech language pathology, for about 3 to 6 hours of therapy a day. And then, of course, I just showed you the picture of our flagship hospital for inpatient rehabilitation, for which sometimes we do see Parkinson's and movement disorders patients come in for specific rehabilitation needs. One of our other core programs is our early intervention program to target people as newly diagnosed or early in their stages of Parkinson's to address a very proactive course regarding physical function, movement, thinking, memory, and speaking, and so forth. And you'll hear a little bit more about our fitness center as well. So what is interdisciplinary care? So sometimes this goes by other names. So you might even hear about multidisciplinary or integrated care or a few other terminologies. And the details of that depends on how the care is delivered and really where the team members are and how they communicate. So you may hear a few different terms, but at its core, interdisciplinary care is an integrated approach coordinating with a variety of team providers. It's an active and engaged coordination of care and services across disciplines. So medical disciplines, allied health, psychosocial disciplines, and more. We interact directly with each other, and it forms a real integration of knowledge and methods from different disciplines. So we can really synthesize all of our unique skill sets to bring them to patient care. It's highly collaborative, interprofessional, and team-based by nature. And front and center is always the patient and their family. So why interdisciplinary care, you might ask? Well, we do know that Parkinson's disease and many movement disorders are not solely movement disorders. They can affect a number of different systems, including mood, cognition, behavior, autonomic function, so blood pressure, bladder function, constipation and bowel function, vision, sleep, and many others that aren't necessarily listed on this slide. So it's important to recognize and provide care across all these different areas in Parkinson's. And it's really important too that this interdisciplinary care goes from not only the time of diagnosis and the early stages, but throughout the whole Parkinson's journey. People's needs change over time, and what we can do and help people also changes over time. Surprisingly, a study a couple years back looking at Medicare database claims of who received physical therapy or occupational therapy or speech language pathology visits, really surprisingly, only about 14 to 15% of people with Parkinson's in the Medicare database were actually receiving these types of therapies. And we know they're very helpful, so we want to make sure we can reach everyone who needs their care. So what we do is, particularly in our clinic, is we do a deeper dive into investigating both motor and non-motor symptoms, exploring treatment options from a number of different perspectives. So I may, as someone who's studied cognition for many years, I may look at cognition one way, but did you know that also the speech language pathologist focuses on cognition, understanding it, and devising strategies to communicate better with cognitive strategies. In addition, the occupational therapist will work with people on a day-to-day function to enhance their cognitive abilities and to plan and work on everyday tasks. And the physical therapist too can look at cognition just as an example by how we might, engage in exercise or multitask. So thinking and walking at the same time is not always so easy. So in our clinic, we'll also look at objective and data-driven information to look at how it informs our clinical decision-making. It enables us to manage and assess symptoms over time. And I truly believe there's great benefit of teamwork for the patients, expanding their care team and including their care partners. But also, I will say, working as a healthcare professional, we definitely, have fun and have a great team communication, and it just makes the work we do all the more fun and meaningful in our lives as well as yours. So just a brief word about our interdisciplinary outpatient clinic. This is a little diagram or schema. So when someone would come see us, they'd see all of the people represented in these colored bubbles to look at comprehensively their symptoms, what it means in their everyday function, looking at their impact, and also their impact on the person and their family or care partners' work, social life, hobbies, and so much more. We'll assess their needs and current levels, and then help decide what the best level of care is, whether it is an outpatient course of therapies, day rehab, or inpatient, or other choices. We'll track outcomes and use those to monitor and look at changes over time. And really, I think one of our central tenets is to empower people, to give them the tools and resources so they can drive their care and help us drive it along with them. So, next slide. So, to talk about our transition from in-person care to telehealth, well, up until mid-March 2020, we were fully in person, and we, outside of the news starting back in November, December, hadn't heard of COVID. And then mid-March, as everyone probably knows, world in the US took a different turn. So we got telehealth up and running in an environment where there was no prior telehealth in about 2 weeks. So talk about massive teamwork and cooperation and moving the needle in a very big way. So 2 weeks to make this full transition, to have a patient-secured platform through the computer system, database, training for team members, how to from soup to nuts, A to Z, how to implement this, access to devices, so iPads for staff members, all sorts of connectivity things, and managing schedules to transition people who were on the schedule for in-person to telehealth. So definitely like a mastermind of activity. And right now we're a little bit of a mix between in-person and telehealth, as we change as the world changes, and we probably help change the world. So just a little bit about telehealth. Interestingly, it's actually not new. So it goes back to even like the 1920s and 40s, when people started to do radio consultations, and then sharing or transmitting x-rays and radiologic images in the 50s. And then many of us may remember from childhood experiences, the Jetsons cartoons, where telehealth seems like such a foreign concept, but lo and behold, here it is with us. And then it sort of faded, after the 1950s, and resurfaced in a number of different formats. But the Institute of Medicine in 2001 made this comment that I think is quite prescient. The internet has enormous potential to transform healthcare. Many of these applications are currently within reach, including remote consultations in the home. And so fast forward almost 20 years to 2020, where this is quite a new reality. Telehealth has actually been studied in Parkinson's disease, and this is one example that was looked at in a randomized control study of what were called virtual house calls. So people had their usual care, but one group were also assigned to have usual care, like in a regular clinic, supplemented with 4 virtual visits by video conferencing into their home. And they really wanted to see, was this feasible, doable, valuable, and beneficial? So 195 patients were randomized, and almost 100% completed at least one virtual visit. What they found in the measures they used was that the virtual care was actually comparable to usual care, but it did save time and travel that you'll hear about subsequently. And then, of course, our new reality and transition to telehealth. So we moved our clinic to telehealth. Here's a picture of us in action. I'm in the tiny little box in the middle trying to take a picture of the team. And really, we just moved everything we did live into a virtual format. So we still do an hour with a physician and the nurse practitioner, and an hour with the health therapy team. Behind the scenes, or by a virtual meeting room, we do a team huddle, and then we regroup and come up with our individualized treatment plan. And really a lesson in communication to coordinate this and transition between the two parts of the evaluation. And then we've worked on our follow-up strategies, which you'll hear about from Sherry as well. So I hope with that introduction, I could set the stage. I know you're going to hear from 2 excellent colleagues on the speaking part, and then be joined by our other excellent colleague, Susanna, and learn more about the role of physiatry in Parkinson's care as well. So thank you very much for your attention.
Okay, we've got the next one. Who's going to share? Is that you, Sherry? No, sorry. I was writing.
Santiago is going to be next. Dr. Toledo is going to be next. Yep.
Dr. Toledo. Okay, great. Oh, you're muted. Here, let me unmute you. Oh, let's see.
You actually have to unmute yourself. There you go.
There you
Got
go.
it. Good afternoon, everyone. Let me see if I can share this now. Not that. How's this? So my name is Santiago Toledo, and I am trained in physical medicine and rehabilitation. You've heard about Shirley Ryan Ability Lab. I'm glad Jen, Dr. Goldman can take you on a virtual tour of the place. At Shirley Ryan Ability Lab, many of our physicians, team members are Physiatrists, experts in physical medicine and rehabilitation. Now, we're often asked, like, what exactly do we do and how can we help people with Parkinson's disease and movement disorders? Physical medicine and rehabilitation, or PM&R for short, is a relatively new field of medicine, both worldwide and in the US. It started in the 1920s. The fundamental goal of our teamwork is to enhance functional performance and quality of life. Someone once said that life is not merely to be alive, but to be well. To put it differently, medicine adds years to one's life, but PM&R adds quality to those years. The philosophy involves treating the whole person, taking care of the whole person with customized treatment programs to improve abilities, to improve function, and hence to improve quality of life. Our allied health experts are crucial members of the interdisciplinary team. The patient becomes the center as well as the care partner. The team assesses the patient as a whole person to look at the function, to determine tailored treatments, and these are all essential to maintain health, prevent complications, and to optimize wellness. The evidence for rehabilitative interventions of Parkinson's is growing. Physiatrists guide decisions directing patients in the process regarding the most appropriate timing and the setting for which to undergo the rehabilitation therapy. Currently, the American Academy of Neurology AN, and other organizations recommend evaluation by physical therapy, occupational therapy, and speech and language pathology across all stages of Parkinson's. And we hope that many people with Parkinson's begin and continue to consult with this specialist. Educating every PD patient is critical. No two PD patients are the same. Functional loss in one patient is different from disability of another. Your PD story is personal. Your narrative, your progression of symptoms, that's unique. It's comprehensive and intricate. Earlier, you heard the benefits of an interdisciplinary clinic from Dr. Goldman. Let's call it an alliance. This delivery model can be challenged not only by access to information, by technological advances, but also by complexities, both organizational and professional cultures. It's not unusual to hear your team say, let's get on the same page, or let's focus on the one patient, let's have a holistic planning. And these are concepts that support the ideas of collaboration. This signifies having something that's patient-centered care. Now, there's other challenges that you may hear about, but they depict more logistic barriers, such as I'm having a technical difficulty, or this takes time, or we have some workforce and staffing issues. The vortex of communication is the interdisciplinary huddle. You've heard that word earlier. It's been a pivotal part of our traditional outpatient care, reaching beyond the clinic room to a vast network of providers, other colleagues, physicians, both for future care and for education. And more importantly, it helps reintegrate the Parkinson's patient back into the community. as it flows through vast levels of care, whether from inpatient through day rehab, through outpatient, into the fitness programs and back into their own homes. Our current concept of a team if a team is graphically represented here. It's composed of members with an appropriate mix of expertise to complete a specific task, who are committed to a meaningful purpose, will have achievable performance goals, and who are all collectively held responsible. So that's interconnectivity. Both physical and occupational therapists, speech and language pathology and nutritionists, psychologists and nursing practice providers, social worker and fitness trainer, neuroradiologists and pharmacists, and these are just among the few. And I'm sure I've seen questions flash by, and feel free to bring this up during our panel discussion. Collectively, we are your providers, and we have to identify characteristics of Parkinson's across a continuum. We set comprehensive definitions of what's in the early stage, what's restorative, and what deserves long-term care. All the players of your care team, and especially the family and their partners, need to be engaged. That's the most important concept there. The physician directs a paradigm shift. So we need a change. We need a difference in the mindset. The patient, I just heard this analogy yesterday, was it? When the patient is the pilot, the therapist is the co-pilot, and the physician is the air traffic controller. So both the patient and the family are thus empowered. Research data reveal evidence-based guidelines for allied healthcare in PD and active implementation of these guidelines. Driven by data, the patient is shown that remote practice can be just as good as in-person practice. Your clinical encounter is empowered with technology that allows your team to focus on patient adherence, patient involvement, and intensive training. And these guidelines are delivered through an expanded care flow, from early referral to restorative to long-term skilled maintenance. So, brings us to healthcare reactions with this pandemic. Telehealth has started to play a significant role in the realm of rehabilitation medicine. In-person healthcare visits have dropped starting March because of social distancing and because of infection control policies. Users of virtual healthcare show a high degree of satisfaction with telehealth services. I'll show you the data on the next slide. And healthcare providers report a manifold increase in the use of telehealth. So how has this pandemic really changed the outlook for telehealth? For the patient, there's been a shift from 11% use of this modality in 2019 to 76% now interested in using telehealth going forward. For the providers, we've scaled telehealth offerings to fill the gaps between what's needed and what has been canceled, what's missing for this patient care. We need to fill those gaps. And federal regulatory guidelines have also been more expanded and have been more flexible with developing new guidelines and regulations for reimbursement, for example. Perspectives of telehealth. As you can see, it is feasible. That's evident. The introduction of telehealth in the field of neurorehabilitation has prompted the possibility to conduct the treatment protocols at the patient's own home. The primary aim for these healthcare interventions is patient engagement, considered the key component in order to promote greater functional outcomes. Telehealth has been considered as a useful resource, allowing patients to have an active role in the healthcare process. In the next 2 decades, empowered patients, radically interoperable data, and scientific and technological advances will transform the healthcare system as we know it today. Virtual health is a component of the future. Virtual health has the capacity to inform, personalize, accelerate, and augment prevention and care. Why telehealth needs guidelines? 97% believe that telemedicine should have standards and guidelines, primarily because they add credibility and they standardize the approach. Also, it decreases liability. Only 4% do not believe that there should be standards, primarily because they do not want others to define the quality of their care, or they think that this is burdensome and too complex to create, maybe not needed. And others still see this as a barrier to innovation and growth. How are guidelines used? The top 3 uses for guidelines developed for telehealth are to set up a new program, such as how we've expanded the Parkinson's Movement Disorders to involve other things like Huntington's disease, for example, or Wilson's disease, and among other movement disorders. Gaps for guidelines are still seen with home health, with teleprescribing or e-pharmacy, and with mobile health. But people don't look enough because there are standards that are already existing for these. Telerehabilitation, for example, covers a number of applications with existing standards that can provide more of a global set of guidelines. And my colleague, Sherry Marchbanks, who's a physical therapist, can expound more on that one. In the field of neurorehabilitation, one of the main objectives is to enhance neuroplasticity by providing strategies directed at the recovery of functional skills, and that is innovation. Access to such interventions, to such intensity, and the number of sessions is important. We can provide care across geographic and time limitations. The role of engagement, keeping the treatments patient-centered, is key to recovery, as I keep saying, and to the quality of life, hence overall satisfaction. However, more studies, large-scale studies, and large data trends should be established so we can look at cost and possible changes in healthcare utilization over the next several months. Key takeaways. Number 1, we are living in a hyper-connected world, supported by ever-changing technologies that fundamentally changes how we assess a patient's health and wellness. Number 2, patient-generated health data combined with analytics can provide clinicians and care teams with both predictive and prescriptive capabilities to intervene remotely. Number 3, supporting a connected patient means that we can leverage common technology that has become embedded in our daily lives. I mean, the smartphone, for example, show me a patient that doesn't have a smartphone, but that can become possibly the digital hub of the future. And regardless of what type of technology healthcare stakeholders adopt, they must ensure that they are creating something that is personalized, user-friendly, and this will be a wonderful experience for our patients, for you. Thank you.
Great. Thanks so much, Dr. Toledo. I'm going to go ahead and share my slides now. Wonderful. All right, I'm going to talk a little bit further about the telehealth rehabilitation services that we have at the Shirley Ryan Ability Lab. So we currently are offering physical therapy, occupational therapy, and speech-language pathology via telehealth and in person at this time for those who it may be more appropriate to be seen in person, which I'll talk a little bit about here coming up. These are all still individual safe sessions that are performed on the telehealth platform, that Dr. Goldman mentioned earlier. And one thing that we've gotten feedback on, which has been very helpful, is you utilize the same room, if you will, every time you meet with your therapist. So you're not looking for a new WebEx code every single time. You come to my treatment room with each session. Who is appropriate for telehealth? First and foremost, the patient, the person who's being seen, has to be agreeable to it. They have to have access to a video capable device or an audio capable device. For those who may not have those things, there are various companies and organizations who are supporting people to get devices and internet connections and things like that in times of COVID. So it's just important to reach out to, social workers or your team to identify if you're having a challenge in that way, and they may be able to help you. Additionally, I know the PMD Alliance is helping people who are uncomfortable utilizing the technology being able to trial those things. And for our team, we are also doing that for anyone who might feel intimidated or anxious about their session. We're definitely willing to trial it with people ahead of time. You have to meet criteria based on physical location and insurance coverage. This is going to be different based on the institution and some of the things that go into documentation, billing, and insurance flows. So that's going to be a little bit individual based on your insurance, your physical location, and whether or not we're able to see you. And then again, there are some patients that we may find as we review records that really need to be seen in person. For example, we cannot give somebody Botox via a telehealth visit. So that's one example of somebody we would obviously need to see in person. Okay, so some of the challenges for telehealth, just like everybody who's attending a telehealth session, for our organization at least, this was very new to all of our staff. So it was quite a trial by fire, if you will. And I think the thing that we had, the advantage that we had was that we were all doing it together. We were able to give each other feedback, and our patients were really willing to share their thoughts and feelings as well. One area we definitely want to be thoughtful of is patient safety. So for example, many of you may have experienced in a therapy session or a visit with your physician, if we're testing your balance or watching you walk, we absolutely want to make sure that you can do so safely. So we've developed some screening questions and tools to make sure that we're not asking people to do unsafe things. A view of the patient is important. For those of you who have not yet seen this, you can recognize that just like a photo, if you take a photo of somebody with a bright light in the background, the quality is very poor. So coaching people through making sure we get a view of them. As a physical therapist, I frequently want to see your whole body. If you're talking to me on a cell phone, sometimes it's a little bit hard to work out placement of that phone for me to see your whole body. Internet connections, especially early on, I apologize. Internet connections, especially early on, were a little bit challenging. I think the world has adapted a little bit and it's gotten much easier, which has been great. As I mentioned before, access and ability to use technology and comfort with that. One thing that we were really thoughtful of initially is in our evaluations, sometimes we take our patients out in the hall to look at walking speed, balance, outcome measures, things like that, which allows the rest of our team access to the family or the care partner who might have some input that they're not comfortable sharing in front of their loved one, or they want to bring up to make sure that we ask about. So we're having to be a little bit creative in how we're having those conversations to ensure that we still get all the information that we need. And then the last challenge that we've identified was how to deliver post-visit information. So typically when you leave our session, you'll get a packet saying, here are our team's recommendations. We think that you should schedule speech-language pathology. We want you to see our dietitian, et cetera. And so figuring out how to do that in a very safe way was a little bit challenging, but we've been able to do so. Some of the great successes we've had via telehealth, which excite us about continuing telehealth in the future, is access to other family members or care partners who may not be able to attend in person otherwise. For example, if you're coming for a visit with us and your child lives in Texas, they can now attend the session with you virtually, which is fantastic. We can reach patients in rural areas who may not have previously had access to coming to our facility 2 or 3 times a week for some therapy sessions. This is allowing our patients to feel safe. I know there's a lot of fear and anxiety around coronavirus and getting sick and exposing yourself and or your family. And this is definitely a way to, fight those fears and avoiding commute time. I actually commute a little bit of a distance to work. And so I've been amazed at what I can utilize my commute time for while I've been working from home. It also allows us to assess somebody in their usual home environment. So very often I hear from patients or their loved ones that, oh, they're just performing. They don't normally walk this well, right? So you're in this really beautiful hospital environment that's really set up perfectly, hard floors, and your gait looks great. And then you go home and you're catching your toe, you're freezing as the flooring changes. And we may not always see that in our clinic setting. So being able to see our individual patients in their home setting, in their own environment has been really powerful. It's also allowed us to make suggestions about changes to the home environment for safety purposes. Our approach really hasn't changed. We've been able to accomplish the same things and just really modifying them slightly. So we're still doing evaluations. We're still meeting brand new patients via telehealth. Some of the outcome measures that we take, this is data, this is information on how we track our patients. A couple of examples for outcome measures would be things like your walking speed. There are specific tests for balance, cognition. There's one called box and blocks for fine motor skills, a 9-hole peg test, some terms you may have heard before. So we had to work to transition some of these online. So the MOCA, or the Montreal Cognitive Assessment, actually is supported fully online now, which is fantastic. We're able to screen share, much like I'm sharing my slides with you now, some of these other tests to deliver both self-reported outcome measures and some other cognitive assessments. I've asked family members or the patient themselves to measure out certain distances to allow us to get things like a walking speed if it's possible and safe. And then we use gross movements to assess strength. So sometimes the doctor may ask you to lift your knee to test your hip flexor strength, and they'll push down on it. So we're thinking about other ways that we can look at that strength without necessarily being able to provide a force. Things like sit to stand can help me as a therapist assess your quadriceps strength and your glute strength, knowing if you're able to get your body out of a chair without utilizing your arms. And then utilizing different outcome measures to assess the same deficit. One common outcome measure we use is called the 6-minute walk test. And that's really gonna look at your endurance. And so instead, we're now doing a 2-minute step test because the 6-minute walk test requires a large amount of space. We've been able to modify interventions like manual therapies, teaching you how to utilize common household items to do those things. One thing I've spent a lot of time with patients on is monitoring your own vitals. So something called the RPE, or rate of perceived exertion, getting an inexpensive blood pressure monitor if you can, and then checking your own pulse in a variety of ways. Utilizing some specific things to make sure, again, that balance and safety are key and crucial in our visits. And then, like I said, utilizing equipment differently. So I think somebody else mentioned, using the coveted toilet paper roll to do some type of exercise. I've had patients use everything from, 20-pound bags of dog food to hold while they're doing a squat to a bottle of ketchup or a bottle of wine to do bicep curls. You can be really creative and use equipment differently than it's intended to be used for. A quick note about, we obviously want the patient to verbally consent to telehealth. We do get a physical location to make sure if we need to send emergency services to you that we have that. We want to, again, have the access to view your home environment and making suggestions. And then we've really utilized different strategies within our own team for communication. Another thing we have to offer is the fitness center. Somebody asked a question in the chat, can you come continually for therapy, or do you have to take a break because of Medicare? That's a loaded question, and you're going to always hear a lot of different responses. But places like our fitness center are really good places to go when you might have a break in your therapy. So they have lots of equipment, they have lots of classes, they have one-on-one sessions available with an exercise physiologist or a trainer. So that's all accessible online at this time, which is fantastic as well. They have online live classes, they have individual sessions, and they have recorded classes that are accessible to everyone for free on our blog, which is fantastic. I was going to show a quick video, a view into our telehealth sessions, but for sake of saving some time for the Q&A, I'm going to skip that. We're happy to send out the link, or you can get on YouTube and type in the search Shirley Ryan Ability Lab Telehealth, and you'll find this cute video of some of our therapists providing their services. And this is, I think, really the take home of all of this is how can you be successful with any telehealth visit? Whether it be your primary care doctor, your neurologist, your therapist, whoever it is that you're seeing via telehealth, these could all apply. So the first is to test the platform ahead of time. Get on WebEx, try it, log in, make sure that you feel safe, comfortable, you know how to change your screen, you know how to turn on and off your audio and your camera. Make sure you have good lighting, like I mentioned before. Try not to have a bright light behind you, but rather in front of you. Make sure you scope out the audio options. You'll notice a lot of us have headphones in because we found that this picks up voices a lot better and drowns out some of the background noise. Think about space and set up for an assessment and exams. So if you're going to meet with a physical therapist, more than likely they're going to have you moving. So thinking about a safe place where you might have access to a floor that has a yoga mat or a towel on it so you can get on the floor safely to do some exercise. Have somebody with you, whether they're physically there in the room, which is great if possible, or somebody else attending the session with you. Much like in-person sessions, we really like to be sure we're getting input from the people who care about you most. Have your medications ready to go, or a list of them, because we will always do the medication check as well. Have your ID card and insurance card ready to go. Write down any questions ahead of time, so be sure you don't forget to ask us anything. And then utilize the patient's portal. If your organization that you work with has the ability to utilize that, it's definitely the best way to connect with the team. So what happens next, and will telehealth continue? This is something we're advocating for and will continue to advocate for. So there are a couple bills that are listed here. The HEROES Act and a proposed bill to enact the Healthcare at Home Act. So those are two great ways to advocate for ongoing telehealth. We really hope that it will. Physician visits via phone have long happened prior to all of this. So those will probably be separate from therapy and how those two continue, but stay tuned for that. As of now, Medicare has extended their telehealth coverage for therapy services through October 23rd. And then each state and each private insurance is slightly different. A lot of private insurances have already extended through the end of the year, but be sure to be sure to check in with your individual provider. And then again, I think we just continue to adapt and innovate in what we do. And we look forward to growing and changing and moving forward with this telehealth platform. If you are interested in getting care at the Shirley Ryan Ability Lab, be it through our PDMD Interdisciplinary Care Clinic, the phone number is listed there. We would request your medical records and or referral from your doctor. And then again, as I mentioned, here are the online programs that we have available, and we're happy to send links and post information to those to Sarah and her team so that they can get all of that out to you. Thank you so much. My email is here at the bottom. I can sort of be your liaison to the team. I'm the program manager here at Shirley Ryan Ability Lab, so happy to answer any individual questions that you might have. And now for a little Q&A.
Awesome. Thank you. Oh my gosh, that was amazing. Somebody just sent me a little note that says, this is way more than rehab. I see this as a comprehensive way to manage one's PD. And also, how can we help people understand that? And I think you're right. It is so comprehensive. And thank you for putting some of those answers in the chat. For those of you that might have missed it, they definitely have social workers. In fact, I actually thought this was interesting. They have wheelchair specialists. They have voc rehab, dietitians, social workers, psychologists. They have the whole team. But we figured we should probably keep this to an hour, and I think somebody said it might be an all-day thing if we covered it all. But that doesn't mean we can't, have another one where we can kind of dive into the additional parts of the team, because I think, this is a really special model. And it is something that I think it's sort of in my mind, what would be the gold standard for how you actually just wrap around full care. And so I'm so glad that people are watching that. Okay, so we've got some more questions here. Susanna, can you tell us a little bit about your communication, the portal, how all of that works?
I'll be glad to. So our patient portal is our secure method of patients having access to us via email. It's sort of like an email platform or like an instant message platform, if you think about it that way, but it's secure. So you can find either, myself, you can find Dr. Toledo, you find Dr. Goldman, Sherry, and you send your message or your question directly to that person, and that person responds to you. It's a lot of hospitals have their own portal, and ours is unique to Shirley Ryan. And definitely, once you're part of our team or come in for a consultation, we give you the tools that you need so that you know how to log in and have access to that.
That's great. And I think, maybe Sherry, maybe you mentioned it, the piece of, if you're in one state and your adult child is in another state, that they can participate in this now. And I would imagine that they can also, if the person chooses to share it with their adult child, they can also participate in the portal, so that really we have a whole lot more support. The whole team's on board.
Yeah. And somebody asked the question if we're on Epic. We are actually on a Cerner system, which is slightly different, but many of our colleagues and collaborators, if you will, utilize the Epic system. That's another great system that is often utilized.
Our portal works exactly the same way as the MyChart in Epic.
Yep.
So it's the same as a just different system.
That's great. And it sounds like you guys, because you're really comfortable and you've integrated technology into your practice so fully, my hunch is that you use the portal. It's not just a big black hole. I know what you're talking about. Every doctor has it, and some think no one reads this, and others are like on it. So I would imagine it's a big piece of yours.
Yeah, and the good thing about it too is you can CC multiple people. So if you're asking a question about therapy, but Dr. Goldman is your physician, you could put both she and I on it and allow us all to have a conversation together.
That's awesome, because most portals don't allow that. You have to pick one provider, and that's awesome. And again, it's the integrated model that you have. Okay, so there was, can you tell us a little more about telefitness? How does that work?
Yeah, I can share a little bit about the telefitness. So the question was, I'll address another question at the same time because I'm a little bit passionate about this. Somebody asked, can you do therapy sort of all the time? And really that's not, as a physical therapist, that's not the goal. The goal isn't to see my patients who have Parkinson's all year long, every year, 12, however many visits in a year, for a lot of reasons, right? It's not practical for you to be coming to therapy 3 days a week, 52 weeks a year, for the rest of your life, right? So our job as therapists is to help assess your current needs, to utilize our skills with you to identify the things that need to be addressed, and to give you a program to work on those things, be it 6 sessions, 12 sessions, 15 sessions, and then to identify things with you together that you can work on to maintain or continue to advance the gains that you've made. So as a therapist, sometimes that means, hey, you know what, we've done 12 sessions. We've really focused hard on your walking speed. I want you to take this into your everyday life. Your home exercise program has to focus on these 4 things. And then let's schedule a check-in in 2 months and see if you're able to maintain that. And if you are, we'll move on to that next goal. We'll start working on that balance, because I know you can work on your gait speed at home. Our fitness center allows us to hand off some of those people who maybe don't feel so comfortable doing it on their own, or maybe really just need that person to give them a little extra push, or need somebody to crack the whip and tell you what to do, or simply need space to do their exercises in pre-COVID times. So right now our fitness center is offering one-on-one sessions. They'll do an evaluation with you. They'll get a nice background and history about what the things you're working on are, how you have done them in the past, how you've responded to those things, and really be able to target some goals of yours by giving you specific exercises, being creative with you, coming up with ways to do them at home, and then holding you accountable because you see them again and you never want to tell the person who assigned you homework that you didn't do it.
True. That accountability definitely helps all of us. Yeah, and I think, I want to highlight again, because there were quite a few questions about, can you access this if you don't live in Chicago? And, maybe I don't know if Dr. Goldman or Sherry, who the right person is to answer that, but I think that's one of the best parts right now. Like, take advantage of this. If we're going to find any little rainbows out of COVID, let's take advantage of the resources that we could never do. Oh, you're muted. There you go.
Aha. Yeah, happy to jump in. And I think, this is one of those silver linings that telehealth and technology has given us during this, unexpected, unprecedented, unwanted time. So we do see people, you know, out of state. Some of it is state dependent. So what we do is case by case, we'll look at that and we'll look at where the current legislature is and insurance and all that. But that does open up some new possibilities that we never anticipated, you know, in terms of getting beyond travel. You know, certainly when the world opens up, you know, in person also can work, and we do have that hybrid model. And then we do have a number of other opportunities, as Sherry and the team mentioned, that are online, free, available to all. We do have some other webinar series, educational initiatives that are now virtual and you know, can be accessible to other people or watch at their leisure. So we can maybe come to you.
That's fantastic. And you know what we can do is we'll send a follow-up note to everybody who registered for this with the contact information. Also, they can sign up to receive those emails, right? Like letting people know when things are going to be available. Yeah, so we'll send all of that to you guys so that you can make sure to stay in tune and engage in those. And a lot of those are on Saturdays, which is really nice because there's not a lot that happens on a Saturday. At least, am I right? Aren't they on Saturdays? Do I have that right? Yeah. And so that's great because you know, there's not a lot of other programming, and this for a lot of people is the only way they're able to connect right now. So, you know, I love what you've done. I know we're over time. I'm not kidding. We might have to create another one because I think that we've just touched on this. And the email, the chats that were in the chat on the side, as well as some of the ones that were sent to me privately, it's very exciting to think about somebody, you know, your team really looking at how to offer services in a very complete, holistic, whole person way. It's refreshing. And I think we need this good news. And I think there isn't a place for it in a lot of our typical mental models of medicine. And I love that you're stretching those boundaries. Kudos to you guys for that. Thank you for that. I am always inspired by this team. Every time I hear Dr. Goldman speak at any workshop I'm at, it's just amazing the amount of information. And then I started meeting this team that she works with, and it's incredible. It's such a resource. So yeah, I agree. This was the fastest hour yet. I'm like, I can't believe we're out of time. So we need to, I see some heads nodding on that one. We need to maybe visit if we can get you back and talk more fully about this model. And I also will say, we'll be sharing information with you guys, but we need you to help speak up and say telemedicine needs to continue. Do not take telemedicine away. We can't have that happen. And we're definitely going to need a lot of voices to help with that. So keep your ears to the ground and watch our emails, because that information will be in our emails. I will definitely send you information on that. And I think we're out of time. I have to let everybody go. But what we like to do at the end is putting on your video, yes, clapping. And one of the ways that we can thank you for being with us today and spending your time with us is through our wave. So our wave is our gratitude, our great gratitude for all that you offer to the community. We are blessed to be with you. Thank you, everyone. See you soon.
Thank you so much, Sarah. Thank you, everyone, for joining us.
Yes.
Thank you.
Thank you.